12 lead ECG review part 1. In this review we're going to discuss the indications for a 12 lead ECG, and we're also going to quickly discuss some basic anatomical features that relate to the 12 lead ECG. So our objectives: describe the indications for the use of a 12 lead ECG and review the main structures of the cardiac anatomy as they relate to the 12 lead ECG interpretation. So any patient that's experiencing chest pain, discomfort, tightness, or abdominal pain of unknown origin in any patient 35 years of age or older, also weakness in any patient 65 years or older, patients that might have experienced syncopal episodes. These are going to be indications for 12 lead, but also patients that have medical history of cardiac issues, especially with complaints and a history of 2 or more of the following: previous acute myocardial infarction, heart disease, hypertension, diabetes, cholesterol issues, lipid disorders. So with our patients with these, the 12 lead is going to be one of our key things that's going to be helping us to get this patient to the care that he or she needs. So really quickly, one of the main structures that we discuss when we discuss 12 lead ECG are the coronary arteries. The left and right coronary arteries emerge from the base of the aorta and fill during diastole. The left main travels behind the pulmonary artery and emerges on the anterior surface of the heart. Length ranges from a short stub to several centimeters. So remember, the left main is going to be your shortest, but it is going to be in diameters is much larger. It bifurcates into 2 distinct branches. The medialmost branch is the left anterior descending, which is going to be one of the coronary arteries that feed a lot of the 12 lead leads that we're going to look at. The LAD feeds the anterior wall and the anterior 2/3 of the septum. The lateral branch is the left circumflex artery, or the LCX. LCX supplies the lateral wall, and it goes on around to the posterior, and in some cases it may even feed the inferior wall as well. The patients that the left circ feeds the inferior wall are said to be left coronary dominant. The RCA, or the right coronary, emerges from the aorta, passing between the right atrial appendage and the pulmonary artery. As it circles the heart, it supplies the right ventricle, posterior left ventricle, then turns downward near the crux, becoming the posterior descending artery, or PDA, and supplies the inferior wall. So you have your left main here that goes down, and it goes into your left circumflex that circles around. Your left anterior descending feeds the anterior wall of the left ventricle, and it feeds the septal wall. You got your RCA as well. Posterior descending artery goes down, and sometimes it feeds the inferior wall of the heart. The cardiac conductive system: SA node, internodal pathways. You got your AV node, your AV junction, your bundle of His, your left and your right bundle branches. Then you've got your Purkinje network as well. So all of these are going to be important when we interpret a 12 lead. We're going to interpret our dysrhythmia first, and then we're going to move on into our chest leads, V1 through V6.